Thank you, everybody, for joining the second webinar brought to you by Resource Optimization Network and Solving Healthcare Podcast. It is with true honor and privilege to bring to you Dr. Dave Neilipovitz, who's our head of our Department of Critical Care in Ottawa, and also the lead in terms of the critical care task force leading our pandemic planning, and the one and only Catherine Sue, Infectious Disease Specialist, who I work with both as a resident. So it is kind of cool to be able to do this. So yeah, we're going to talk about personal protective equipment. There's a lot of questions regarding what is needed. There was some inconsistencies out in the literature. So our goal was to really solidify what the evidence is out there and to give some guidelines in terms of why these recommendations are the way they are. So without further ado, I am going to bring you Dr. David Neilipovitz.
Thanks, Squad, and thank you, Kathy, for agreeing to do this with us, because certainly we're jumping into the deep end. When we started working on this, I was worried, and after doing it for a while, now I'm afraid to present, because I tell you, this is like doing a talk on politics or religion or the environment. No matter what we're going to say today, we're going to offend someone. And someone's going to be unhappy, certainly with me. No one could be unhappy with Kathy, but let's do our best. And she'll be the voice of reason. She'll provide the sage advice. She's the person behind the curtain there, moving all the devices on in the Wizard of Oz. And I'm sure she'll agree with me that to present evidence-based, sound presentation on PPE isn't just beyond hard. It's near impossible. The evidence is simply poor. It's also hard because the environment is so poisoned by different opinions. The fact that we keep changing recommendations, it just simply undermines everyone's trust in what's being presented. But we're going to do our best. And Kathy, I'm sure you'll make it all perfectly clear for everyone before we're done.
Sure, Dave.
There we go. So with that kind of proviso, and please remember that these are recommendations as of April 18th. You know, who knows what will come out tomorrow or things as such. So we'll say that several times today. These are the best available recommendations for the given date. So if you're watching this at a later date, recognize things could have changed. And it's not the same in every jurisdiction. So if you're watching from afar, you'll have to know what your local environment is like. Let's face it, there's no place in the world right now that has enough PPE. At least we're not getting beaten for protesting that we don't have enough PPE. That's a scene from Pakistan. And I think Quad will attest, I'm not a big fan of government, but for once, I'm actually not laying all the blame at the feet of our government. People say maybe I'm drinking the Kool-Aid. Or as my colleagues like to say, that I'm making the Kool-Aid. Just note that it's cherry flavor, if you're curious about that. But these shortages were simply incredible, hard to avoid. And someday I'm sure there'll be a royal commission to look at this and find recommendations to help avoid it in the future. But let's face it, PPE costs a lot of money. The other aspect of it is that the stuff expires. And so to have enough on hand for a pandemic would be certainly challenging for any country to do. And look, Canada is not unique. Everywhere in the world has been challenged by this. And so I think our goal here today is to come up with a rational use of it, how we can use it to the best and most efficacious way, and as well as have some strategies how we can increase our supply of it. Kathy, I don't know if you have any thoughts about this or.
No, I think that sets the stage very well.
So with that in mind, this is such a loaded topic for people, and I think the reason being is quite frankly, it's such a serious situation. And I don't know if everyone recognizes Dr. Wen Lang. He's the ophthalmologist, if I recall correctly, from China, who started sounding off the concern about this back in early January. And unfortunately, the irony of irony is that he ended up catching COVID-19 and unfortunately succumbed to it. Rumor has it that he was even placed on ECMO, but was unable to recover from the disorder. And so certainly I think that really kind of brings it home to all of us health professionals who are dealing with it. In terms of the issues, mistrust is huge. And as I like to say when I'm talking with students and things, the hardest thing for us to establish with families, but the most important thing is trust. Certainly in this situation, there's considerable mistrust. There's anxiety about things. And it's the belief that the decisions are often being driven by economics, which if anything, I don't think is the case. But it adds to the cynicism that everyone has when recommendations get put forth. And mistrust is huge on PPE. I'm sure, Kathy, you've experienced that as well.
Yeah, definitely.
One of the big underlying issues is the fact that when you see what the recommendations are put forth, and I've done a lot of reading on this now, and what I realize is there's not a lot of good evidence out there. And a lot of it is citing the same examples, but interpreting it different ways. When you look at the studies, most of the studies for this were based on SARS, which were case series or case controls. They're really of limited quality. For example, they would say we had 4 cases, this is what happened, and this is why we think it happened. And so there's a lot of limitations in what the recommendations are based. There's also extrapolation from other diseases and disorders, which is understandable when you don't have a lot of available evidence, but they're not perfect and they're not perfectly transferable. I'll use an example as well and we'll talk about it later, but the aerosol-generating medical procedures. If you look at some of the recommendations for this by the different countries, you'll see that they differ significantly. And that's quite ironic, at least for me it was, because they all cite the same references. So somewhere, somehow, things got lost in translation, and that there's the subjectivity and, unfortunately, opinions that get put into the recommendations, which, for me, leads to confusion and mudding of the recommendations. Kath, you've read more of the papers than myself. Like, am I missing the accurate ones or the high detail ones or high quality ones?
There aren't very many high quality ones, as you said. So I would agree with what you said, Dave. The evidence is for many of these recommendations very, very limited. And as researchers, we'd say the quality of the evidence is really low, but it's what is available. And that's unfortunately the foundation for many of the recommendations that we have today. And again, particularly with the use of N95 respirators and aerosol-generating medical procedures. But there are also questions that are related to PPE in general when we're dealing with these patients where there isn't a lot of evidence, but if you can apply logic, much of it should make sense.
That's absolutely right. It's the best available evidence. Logic, I wish would prevail.
Common sense?
I say I wish logic would prevail, but at times when it's emotion and things as such, it's understandable that sometimes that's secondary. What's very true for this situation is there's so many voices and opinions that are being presented. And let's face it, people are getting a lot of their recommendations and evidence from Facebook or Google, or they're sitting at home watching CNN or various news outcasts. And again, a lot of this is then mixed with expert opinion and recommendations from various societies, unions, professional groups. It really muddies the water. I'd say it's fake news, but that's too painful a cliche to use for something so serious. For me, it was especially problematic when you see that the sources are often the same, but the recommendations are quite conflicting. So there's too much noise. That for me was problem number one looking at it. So we're going to do our best to simplify, go back to some of the sources and try to clarify, and more importantly, try to give stuff for everyone to how can you use it in your day-to-day process. So that's the goal, that's the issues. Let's get underway. Not going to spend too much time on the NIOSH. For those who actually wonder what it stood for, like myself, you can see what it is. This is a hierarchy of controls for preventing and protecting individuals. And I think the most important thing for me from this is the fact that PPE is the last line of defense. It is the least effective line of defense, but has the highest profile. And it's typically what's under control of the individual, as opposed to society or governments or even hospitals or groups. So everyone focuses on that aspect, on PPE, but to do it justice for the protection of our staff and other patients, I think we really need to keep in mind when addressing the issue to use the full gamut and look at the more effective tools, which, you know, it's hard for us to eliminate the problem, but certainly the engineering controls, that would include various forms of isolation, physical barriers, proper ventilation of rooms. That reduces the opportunity and the impact of human error on causing problems. The administrative controls is what I think a lot of us have seen and are familiar with, but this includes various policies and procedures, various training and education. And it's even simple things like enhanced signage, reducing visitors, and cohorting patients in various fashions. Kath, other aspects of the hierarchy that you would like to highlight for the audience?
Clearly the first two, elimination and substitution, are not relevant here. I think engineering controls are the most important. Unfortunately, most of us are working in facilities that do not have optimal engineering controls. And so we're left trying, those are not really readily modifiable for most places. And we are left with basically the infrastructure that we have. So Dave mentioned some things, but for example, in future planning of new facilities, things like all private rooms, the ability to have negative pressure in every room or a negative pressure unit, having split emergency rooms, or the potential to be able to split your emergency department so that if you have another pandemic like this, you can readily have symptomatic patients go to one side and non-symptomatic patients come to the other side. Most of our facilities in Ontario certainly are older and can't accommodate or don't have what we would consider to be optimal engineering controls. Administrative controls, Dave had mentioned, and really those are, we primarily think of those as policies and procedures and guidance and structure to what we do every day. I would definitely agree that PPE is what everybody focuses on, because the impression is that that is what is most important for protection. And in fact, it is definitely the last thing in the hierarchy, but it is what is most relevant to healthcare providers on the front lines.
Great. Thanks, Kev. With that said, we're going to focus on PPE because obviously that's the topic here. A little background, though, about COVID-19 and related types of a problem known as SARS. Now, I think we all know the World Health is now struggling for its funding with the recent decision, but for the most part, the message delivered from the WHO has been pretty consistent. I won't get into the issue of whether they should have declared it a pandemic sooner. What many don't recall, if I recall correctly, was they were criticized for calling H1N1 sooner than others felt they should have. But what I will like to highlight on this is the fact that they do consider this a droplet disorder, and we'll go into that in a little bit more at length. I would also highlight the fact they talk about the 1 meter. And I'll bring this up not because to get petty or that. You'll see that in the Canadian recommendations, they've doubled it to 2 meters. Again, it was all based on the same studies and founding studies. Again, people have added and doubled, I'm sure for enhanced safety reasons, but what it does do is create confusion when people are comparing different recommendations. In terms of the disorder, you can see that they focus on it being droplet or so-called fomite, where basically someone coughs on a surface, people touch it, and then touch their face, their mouth, and transmit it in that way. They do talk about this airborne transmission, but they say that that might be possible in certain procedures, which we'll discuss at length. But they do claim that of the 75,000+ cases, that there was no reported airborne transmission cases. Kath, I don't know if you have any thoughts on what the WHO said, or likely that will come out as we discuss COVID in greater detail.
Yeah, we can discuss this later, I think. Well covered later.
Yeah. So what kind of disease is COVID-19? It is a droplet disorder. Not only was it the WHO stating that, but most other organizations, provincial or federal, are saying very similar. The fact that countries have managed it reasonably successful, like similar coronaviruses in the past, which only required surgical masks, does support the fact that it is most likely a droplet disorder. And perhaps we should dive into that in a little bit more detail. What does it mean to be droplet, and what does it mean to be airborne? And this talks about how the disease is transmitted. The classic airborne disorder is tuberculosis, whereas the droplet ones of significance include influenza and SARS. If it was an airborne infection, which the classic being TB, the particles that are expelled by a patient are small. What they talk about being below 5 microns. And these so-called droplet nuclei can remain suspended in the air atmosphere in the room for extended period of times. How long? It depends on room exchanges and ventilation, but they remain suspended and therefore can get inhaled. And the recommendation is to use an N95 mask. What's interesting, and perhaps Kathy can comment on in just a minute, is the fact that you don't require a shield or goggles. And I often wonder if the individuals who are so adamant about requiring an N95 would then be willing to eliminate the eye protection. Because if it was truly an airborne disorder, you wouldn't require it. And certainly I'm not recommending no eye protection. But if it was strictly airborne, that would be the case. In terms of droplets, they're larger than 5 microns, that they're transmitted up to about 1 meter. And again, the recommendation would be to have surgical masks for this, along with the eye protection. Kath, can you clarify any of that? I think you're on mute.
Sorry, no, I know my spacebar wasn't working there. Droplets, I think, historically have been considered to be larger, typically moist, but obviously invisible particles that will fall to the floor with gravity. And previously, we used to say 1 meter. There has been extension of that, certainly in Ontario and I think most of Canada, to say that droplet transmission could occur within a 2 meter radius. The difference is that these really are spread within that 2 meter radius. So they are not going to be transmissible if you are standing farther than 2 meters away, even in the absence of personal protective equipment, whereas the airborne infections will travel with air currents. And I think it's just important to remember, and when we talk about aerosol-generating procedures, we'll get into this a little bit more. This is a droplet transmitted infection that we're talking about. Again, so yeah, we'll get into more detail later.
And we'll build on that, Kath, because I think you'll agree that that's where a lot of the confusion is generated, and confusion with what the recommendations should be. SARS, and Quad, I don't think you're old enough to have had experienced that, like Kathy and myself. And obviously, we experienced the fallout. We weren't in Toronto, and certainly it had devastating and long-lasting impact on individuals in Toronto. The number of deaths were significant. I'm trying to recall correctly how many health professionals passed away, and for some reason I think it's 17, but I'm not sure I'm exactly correct on that. So certainly that was quite significant and was a tragedy. We did learn a lot from it. At least in Ontario, it helped us prepare for this pandemic. Unfortunately, a lot of the preparation and process and recommendations seem to have been, unfortunately, dismissed or ignored when people approach this, but a lot of it did translate, and that's why I think Ontario was certainly better prepared than other areas for it. What was definitely learned from SARS was the huge importance of hand hygiene. Again, they cite the example of Vietnam was able to terminate the SARS without any airborne rooms, without any N95, but simply just good hygiene along with surgical masks. And you know, they still have airborne disorders in Vietnam, so it wasn't in that regards. The case you'll hear cited often is this Hong Kong Amoy Gordon's, where they felt that an improper sewage disposal system caused this rising fume of SARS and caused an apartment complex to get problems with infection. I read it. I'm not sure I totally understand it, but certainly it seemed very scientific in the New England. But a lot was learned from SARS. It is a coronavirus. I think the lessons from it are readily transferable. Kath, I don't know if you want to build on SARS or.
I think it, for those of us particularly in Ontario, it frames a lot of why we do what we do today in Ontario, and particularly with this new coronavirus and this pandemic. A lot of the initial guidance that came out in Ontario was based on what we refer to as the precautionary principle, which were essentially lessons learned from SARS. And until we had a better understanding of what this coronavirus was and how it was transmitted, even though many of you may realize that there shouldn't be a reason why it would be transmitted differently from other coronaviruses, but this being a new infection, we, in Ontario, opted to provide the highest level of PPE as our recommendations. That is the precautionary principle, before scaling back. So many in Ontario are still, and particularly if there's anybody who worked in Toronto around the time, many will remember that very clearly and the fear and anxiety it created. And it, as I say, has sort of shaped Ontario's approach to this, at least initially.
Yeah, no, that there was a lot learned from it. They'll talk about the intubations and the nosocomial spread, but perhaps that we'll save that for our discussion if there's time. But again, a lot of lessons learned. We'll pick up the pace a little bit. I'm cognizant of the time. The CDC in the United States has put out recommendations for PPE, and to be perfectly honest, they're kind of sitting on the fence. You see what they have their preferred is, which includes the N95 respirator, but they actually do say, interesting enough, an acceptable alternative is simply a face mask. Again, we'll dive into that a little bit more. They do talk about it being primarily a droplet disorder, again, with the foam-like transmission, the same as the WHO. They fully admit that airborne is uncertain, and their recommendation is, however, to ideally have an N95, but again, we'll have an acceptable alternative. In Ontario, where many of us practice, the present recommendation for PPE is for the use of an isolation gown, and I won't specify, but it is written what level of gowns. There is a grade to them. They also recommend the use of eyewear, be it goggles or a visor, along with one pair of gloves of a certain type that cover up the cuffs, so the picture is a little bit incorrect. They also talk about masks, and there is a proviso of what type of mask to wear is a little bit, it depends. So the two types of masks, one is the so-called procedural surgical mask, and that is standard for droplet disorders, and that is the recommendations for the vast majority of situations related to COVID. They do talk about the N95 respirator, and that is cited as a recommendation for the much beloved aerosol-generating medical procedures, AGMPs. So we're going to dive into that a little bit. Kath, I don't know if you have anything to add, or we'll move on a little bit there. So what are AGMPs, aerosol-generating medical procedures? Now, I'm going to say that this is the biggest issue I had with PPE recommendations, and this is probably the issue that for me was the most poorly described and has created the most confusion, problems, arguments, and has actually caused probably significant damage and mistrust. When we talk about aerosolization, clearly words matter, and you can see that aerosols and droplets get incorporated into it by the definition and how it's used, and that just adds to the confusion. It's very subjective, subject to misinterpretation, and the recommendations from it, quite frankly, keep changing. But some important take-home messages for me, and perhaps Kathy, you can expand upon it, is the fact that aerosolization is not synonymous with airborne requiring. And I really think that a better term would be calling this droplet generating procedures, but perhaps Kathy, you can help clarify this for everyone, because I think this is the root of many of the issues and concerns about PPE.
Yeah, I agree entirely. The word aerosol really means that you are generating liquid particles. Either the patient is generating them by an activity such as coughing or sneezing, or we are actually inducing that in a patient through activities such as bronchoscopy or intubation, for example. And the fact that we have in all of our aerosol generating procedure recommendations for COVID that you should be wearing an N95 respirator and ideally perform the aerosol generating procedure in a negative pressure room automatically leads people to think that this is an airborne transmitted infection. I shouldn't say automatically, but I think frequently would lead people to believe that this is an airborne transmitted infection, when in fact it's not. So just the use of the word aerosol generating, if you go back to the definition of an aerosol is a suspension of liquid particles. And for droplet transmitted infections, most of those liquid particles will be droplet sized, and they will, again, just as if a patient coughs, they will fall to the floor once the procedure is done. And so technically, once the procedure has been completed, let's say an intubation, there should not be a suspension of airborne particles in the air. The droplets should have fallen to the floor and your aerosol generation should have ended. So the practices that we are recommending now actually probably exceed what is required when we're talking about aerosol generating procedures. They probably exceed what is required for a droplet transmitted infection. But again, being on the safe side and employing the precautionary principle, we have still recommended the N95 respirator, the negative pressure room when those are available. But I think it does lead to a lot of confusion, and there is a tendency to equate an aerosol generating procedure with an airborne transmitted disease. And with the exception of TB, measles, and varicella zoster, we really don't have any other diseases that are truly transmitted by the airborne route.
Thanks, Kat. And I'm guilty of that, but we decided to use airborne rooms for our procedures. We even talk about how long afterwards you need to leave, the door needs to be closed. Again, I think unfortunately we've taken airborne disorders, how we manage airborne disorders, like you said, TB and measles, and now extrapolate it to this, and I think that certainly has contributed to the confusion.
But I would also say that our provincial guidance does recommend that we follow those procedures in the off chance that there's something that we don't know about this infection, and we just want to make sure that we're providing our healthcare workers with the safest options.
Excellent point. Excellent point. Where do these recommendations come from? And this is the only study I'm going to talk about because nothing's more painful than people diving into studies during presentations. But this is quite important because this is what's cited by the WHO, by the CDC, by the Ontario recommendations. And sometimes they'll cite the WHO recommendations, which, was a 110-page document. And if you go to it, it's based solely on this systematic review. And no fault of the reviewer. They can only review what is available. But they clearly said in their review that they considered it very low quality using the grade criteria. But you can see 10 studies were identified, all involved SARS patients, 5 case control, 5 retrospective case series like presentations. From that evidence, you can see only 4 procedures placed the operators at significant risk. And you'll say, hey, that's not our list that we're using, but this is where the evidence comes from. You can certainly see endotracheal intubation by far and away is the greatest risk based on 4 trials in both cases. But again, the rest of it is of limited evidence. And I think that's why the recommendations are so muddy. Kathy, you've probably read the studies that went into all of this. What was your opinion of the review? Was it fair? Reasonably scientific?
I think the This systematic review, this was also, this is the CADTH report that was then published as the same systematic review the following year in 2012. These reviewers really were faced with trying to come up with some conclusions based on observational and low quality primary evidence. So it's very difficult to really know how significant the risk is from these different procedures. The other thing to just remember is when you go back to the primary papers that are included, many of them are observational or small cohort studies. There are a number of different factors that you don't see when you're only looking at the odds ratios that are associating a procedure that we recognize as being aerosol generating with healthcare worker illness. So the absence of use of any PPE, for example, incorrect, or what we would know now would be inadequate personal protective equipment. So perhaps wearing eye protection, but not a mask, or vice versa. The absence of hand hygiene, careful observation of how personal protective equipment is removed so that there was no option for self-contamination or self-inoculation. Those details are missing when you look at a table like this, but when you read the papers, there is some discussion in some of them that clearly point out that healthcare providers who were infected were not following what we would consider to be just basic routine practice, i.e. droplet precautions today. So I think that that gets lost when you look at these odds ratios and the AGMPs that they're associated with.
Thanks, Kat. That said, this is what has certainly influenced subsequent recommendations, which we will go through. For Ontario, as of April 9th, this was the latest recommendations that could put together from our IPAC team. The list keeps changing. So again, check your latest list, but it's important to see what's not aerosol generating. And I think that is something that is certainly a good place, at least for me, to start. Ventilator disconnects, which has certainly caused a lot of confusion in our ICUs, but is clearly on the list as not aerosol generating. What's also unclear is how we are to apply the AGMPs. At least for me, was it just a COVID positive or possible patients, or was that for all? I know for our institution in our ICU for non-invasive ventilation, we took the decision to apply that to everyone at present time. But again, it will be interesting to see how people will apply this. We'll go through three that some are on the list, and we'll go in more detail about extubation, CPR, and high flow oxygen. But Kath, I don't know if you have any comments for the list and any corrections that might have happened in the last 24 hours or something since the slide was made.
No changes to this in the last day that I'm aware of. Yay. But I think it is quite controversial for some of these things, and the reasons for that we just discussed with the previous slide. But I would say particularly for those in Ontario, we have a list of what is considered to be aerosol generating procedures that is provided to us by Public Health Ontario. And if you are not within Ontario, then I would certainly refer to what your own jurisdictions consider to be aerosol generating procedures. I will say, though, that even between institutions in Ontario, there are things that you will find added to this list that, there is obviously some additional discussion that goes on within institutions. But the evidence for some of those procedures, and in fact, many of these procedures, in terms of being truly aerosol generating to the point that they require an N95 and a negative pressure room, is questionable. CPR is something that you will see on some lists, just chest compressions. They can certainly, if they're forceful enough, generate droplets from a patient, but they would not generate airborne particles. And if you are wearing routine droplet droplet precautions with a procedure mask and eye protection, then you should be protected from those droplets. And for many, well, I would say for most of these AGMPs, wearing a procedure mask or surgical mask with eye protection would be an effective barrier against inoculation and therefore the healthcare provider acquiring infection.
Totally agree, and we'll present that in a little more detail, but absolutely, totally agree with that. Probably the one that's not, has been on the list and wasn't on the latest list, and was one that, I'll be perfectly honest, I thought initially should be on the list, was the idea of extubation, the removal of an endotracheal tube. And again, I think this is because, yes, the patient is likely to cough very frequently. It creates a lot of droplets, but it's unclear, is it aerosolization of it? Does it create an airborne-like disorder? And for me now, it's not as clear. And I think the fact that you go to a cough and a sneeze not being an airborne problem is important, and that's where we keep going back that it's a droplet disorder. And initially, when I put the image of the person coughing and the lovely lady getting a face full, I thought, oh, this is inflammatory. People are going to say, look, that's perfect evidence. But you look even in that small little space with the camera and whatever, how there's rapid dissipation of the droplets. You know, none of us have said that there is no droplets being generated in things as such. But again, the fact that within 2 meters, most of these droplets, you know, have already fallen and aren't being suspended. The recommendation of having a full mask with eye protection, you can see why eye protection is so important for this, you know, for me would mean for extubation, although every person in Ontario is granted the ability to make their own decision on what he or she feels is most appropriate, you can see why extubation isn't uniformly on everyone's list as an aerosol generating medical procedure. What do you think, Kath?
I agree, Dave. Nothing more to add there.
So again, that may be surprising for people, but you know, with the idea of wearing a surgical mask and a face shield is probably more than adequate for this aspect of it. I won't belabor about CPR as Kathy's already talked about it. As I like to tell people, it's kind of 2/3, 1/3. The idea of chest compressions and defibrillation are certainly not aerosol generating. The fact that airway management, if you go back to the basis of all the recommendations, probably the highest risk. As many know, in our institution, we elected to go with an LMA with a HEPA filter on to try to decrease the risk. I'm not saying that's the best management strategy for CPR. The issue is if people are going to do what some were advocating, to go to an airborne room to get a glide scope for video laryngoscopy, the delays in doing all of that would certainly mean that the chance of having a favorable outcome with the patient would be highly unlikely. But I'm sure we'll revise our protected code loop approach. However, if you look at the evidence, it's probably the airway that's the most contentious aspect of it, as Kathy already discussed. Anything to build on that, Kath, or no? Okay. The final thing just to highlight about the aerosol aspect is the high flow oxygen, and I think this is the one that I find the most troublesome that keeps getting on the list, because if you go back to the evidence, I've not seen any evidence to support that it should be on the list. You look at some of the European recommendations, it's not there. It's certainly highly advocated for the management of COVID patients. reports out of Italy, along with other European sites, along with Seattle, certainly would suggest that it has a role. We at our institution here have an oxygen screening for COVID-19 that we put together and are using to help manage patients. And again, part of the aspects is to use the Airvos and various related devices. So right now for us, we would consider it aerosol generating, except in certain circumstances. Again, it's hard because we have to abide by our provincial rules, and what our logic and what our hospital is suggesting is perhaps a little bit different. Kath, other than me confusing everyone, are you able to bring clarity to the topic?
No, I would just confuse everyone more.
Okay, there you go. What also confused everyone was this study, or this report that was put out in the New England, where they talked about persistence of aerosols, more like an airborne type of disorder, that they were able to generate with the new coronavirus as compared to the one that caused SARS. So they talk about using a 3-jet nebulizer with a Goldberg drum to create an aerosol. So I think if you routinely use a 3-jet collision nebulizer and a Goldberg drum, that you should consider that aerosol generating medical procedure. I'm not sure the significance of this for our management. Certainly it caused a lot of confusion. The significance of RNA samples being detected as well in the air, that doesn't necessarily mean the virus is viable. And I think that's a hard concept to appreciate. Perhaps, Kathy, you can explain it better than I did. Well,
I think probably most people appreciate that PCR is really just looking at specific, to really simplify it, specific sequences or targets in nucleic acids. So the fact that you can detect those specific targets doesn't actually mean that there is viable virus that you're detecting. And that is not a limitation of PCR only with COVID testing, but any PCR that we are using clinically may have the same limitations. This experiment is also similar to other, you will find, quote, evidence of other pathogens being airborne. Influenza is one, coronavirus is the other one, based on some experimental studies like this. And those are not, they really haven't been replicated in vivo. Well, obviously you couldn't replicate this in vivo, but much of the evidence that is used as support of airborne transmission is in fact experimental evidence.
Thanks, Kat. So with that said, we recognize that the recommendations is the use of surgical masks, except for the specific procedures we've already gone through, along with the use of gowns, gloves, and eyewear protection. What do you do with the shortages? And let's face it, there's shortages everywhere. I was getting emails every couple of days saying how, I could order it from some disreputable person who was trying to sell things. When you look at how the prices surge, it's amazing. 6 times for surgical masks, other things a little less so. To meet the rising global demand, the WHO estimated that world production had to increase by at least 40%. And so a rational and appropriate use of PPE was certainly urgently required for all of us to abide by. What could we do? Well, again, let's increase our supply. Now, that's perhaps easier said than done, and I think we're all familiar with companies trying to repurpose and do a shift to increase production. My favorite was the beer companies suddenly producing hand sanitizer. I have mine here that a colleague of mine was able to secure. So we do have it, and certainly appreciate if the company's doing so. 3D printing suddenly has gotten vogue, and you can see my ugly mug there. But our 3D department has done an excellent job helping with this, as has the community. Again, where these versions fit in, that's perhaps a different discussion, but certainly it's been helpful. The donation of supplies, I think we're all very grateful. What you see there is a R95 mask. And, 3 or 4 weeks ago, I learned the difference. It's in terms of oil penetration. N stands for no, not resistant to oil, whereas R95 is partially resistant, and there's a P95. So again, they can be substituted and the supplies of those have also been consumed. Other strategies to increase your PPE is first and foremost is to decrease inappropriate use, and that is a very contentious topic and filled with emotion, and I don't say that flippantly, but certainly we need to have appropriate stewardship. Hearing people going in for 2 minutes, coming out to answer something, and then going back in with new equipment, that kind of stuff, certainly I don't think anyone would agree that that's a good use of PPE. So we need to do what we can to use it appropriately. There's strategies I think all are very familiar with to limit the need. To minimize contacts, minimize the number of people going into a room. So although we are in our teaching location, we shouldn't be consuming it in that way. Restrict the N95s to appropriate procedures. Again, I realize that can cause emotional and anxiety, but if you base it on the evidence and sound recommendations, that is something to strongly urge and consider. But we also need to change how we do things, practice differently, to decrease precautions sooner than later. If they're not fully required, then ideally we should get patients off of that. And perhaps if there's time, we'll talk about how to discontinue COVID precautions. But again, these strategies certainly are important to help increase supplies. Kath, anything to add? Or
Dave, you're doing such a great job. I don't need to add anything.
Okay. This is where we start getting a little bit crazy. To increase and optimize the length of use. Again, there is recommendations that come both from WHO, from Provincial. The fact that you can use it for multiple patients, and now you're not going to go from a COVID positive to a COVID negative, but if you have similar cohorts, there are recommendations that allow for this. Certainly replace it if it's wet, damaged, or if you've soiled it, if you've touched your face, then certainly that should be replaced. The N95, and certainly with all the shortages, our site has had to do additional testing. Recommendations would be for the test to use out-of-date N95 masks and perhaps limit who requires it to those who will actually use it. But again, there's also the potential of repurposing the masks for later on. The alternate devices, and you can see that certainly we're exploring every possibility. That's a scuba mask or snorkeling mask, and we're to try to get that tested early this week. The idea, you can see the valve has been adjusted. If you think I'm just making it up, I have that, I guess, as my backup in case there's an issue in the office here. But again, it's a possibility. The use of alternative devices is advocated. But again, this is fifth line in the recommendation. This isn't top of that. And the question really is, are these safe? And I don't think we are able to easily answer that. And we're trying to see if they're effective. And so it'll be interesting to see how it works in our screening test. I won't spend a lot of time on PAPRs. It's interesting that they are designed for airborne disorders. They're heavy. I've been trained on it, but my training's probably out of date, as Kathy will attest. You often need a spotter, and there's actually evidence that paradoxically, you increase your contamination when you're taking it off. what are your thoughts on PAPRs, Kath?
So PAPRs, I think, are in keeping with many other questions that we've had about additional PPE. So adding things beyond what is, sorry if you can hear the helicopter in the background, adding to what is typically recommended. And in the photo, you can see this individual, hang on. That probably won't help very much. In a one-piece Tyvek or other suit with boots and tape holding everything together, the more you add, often the more difficult it is to get out of, and the higher your risk of self-contamination. So PAPRs work. Our main challenge with it is that the majority of our healthcare workers wouldn't know how to use them safely and properly. They also do require 2 people to get out of when you're talking about removal after potential exposure to an infectious pathogen like COVID, for example.
Excellent. I am cognizant of the time, Claude. I think we're okay to go past 1, are we? Okay. So not to worry, everyone. We are cognizant of the time, but I think we can go 10, 15 minutes afterwards if Kathy's okay with that. The final strategy for increasing, prolonging PPE, and this is very contentious, obviously. This is where you get into reprocessing PPEs. I know our institution is collecting them. This isn't a new idea. This started about 3 years ago. There's some research looking into it. Obviously, it makes individuals uncomfortable, and this is not first-line recommendations, but we'll see where that goes, and if they're able to do it, you know, we'll adapt. Some of the other unorthodox is to use other countries' standards. Out-of-date ones, I'll be honest, that one doesn't concern me as much as others, but perhaps that's my personal bias. As opposed to using a different standard, I'd rather use one that's out of date to some degree than a different standard. But again, ideally we have an adequate supply of up-to-date equipment. And that is some of the strategies to do it. Before we do our question and answer, I had a few questions that I thought can start off. These might be some FAQs that at least I've experienced, and I suspect, Kathy, you've done it as well. What do you think about neck coverage? Is that absolutely required, particularly for those intubating?
I think the issue of neck coverage has definitely come up. There have been some, I'm going to call them experimental studies or experiments where there has been demonstration of droplets contaminating the neck with intubation if you're actually equating glow germ laden liquid with sputum. I think internally we've addressed that for the most part using longer face shields, so that when you actually are intubating, in fact, there is adequate coverage and protection of your neck, and there is no space that's left between the bottom of the face shield and the gown.
It's a great point too, because I get a little bit nervous about people removing like any kind of neck coverage in terms of getting themselves contaminated.
Yeah, and that's a good point also, and that goes back to the statement that anytime you add an additional piece, particularly when people aren't used to it, we know that it's more challenging to get out of, and again, just adds opportunity for self-contamination.
Excellent point, and I can certainly appreciate the challenges, and it's understandable people don't want their neck exposed. It's if the solution is worse than the problem, is always a concern that, as Claude has alluded to. Perhaps related to that is the use of enhanced barriers, and these are these intubation shields, and Kathy will know there's still some in my office trying to distribute them. I guess I have mixed feelings on these. if it's close, I can understand how it would prevent some of the release of the droplets up. I am worried about making it more awkward for myself when intubating. And I guess the other question is, how do we clean them to ensure that they're adequately clean? But what are your thoughts about these enhanced barriers, or so-called intubation shields? Because it does fit into that hierarchy if you go back to it.
Yeah, I think the points that you've made are just things to consider. And the other also is, depending on the patient, is there any unexpected adverse effect on the patient? If you're having more difficulty intubating and the head is in a little box, I'm not sure if that actually will complicate things or compromise the patient in any way. Certainly with anything that is purpose-built for things like this, we always like to know that they are actually compatible with cleaning disinfectants that we have in hospitals. There's little point in bringing something in that we're going to destroy with one attempt at cleaning. But I don't know again in other centers how widely rolled out these are. But I think with, if we're able to ensure that we have a continued supply of adequate personal protective equipment, I'm not really sure if they'll be needed. As somebody who doesn't intubate, as many of you will recognize, that's, there are obviously specifics that I can't comment on though, but I'm not sure where they fit in.
And I guess I'm still a little bit out on my opinion. I certainly didn't want anyone to feel that we didn't care about their safety, so certainly that's why we proceeded with it. Removing COVID status to preserve PPE. Good idea, bad idea, false reassurance. What are your thoughts?
So the way we work is that if somebody has been tested for COVID, our assumption is that there's a reason why they've been tested, and they haven't been tested for just because, or because they came from a retirement home, or because they're pre-op, or because they might have known somebody else who was sick but not a COVID patient. So I think first of all, we need to be careful with who we're testing. And again, for everyone in Ontario, our testing guidelines have been updated, I think twice in the last 3 days. So it's hard to keep track of, but there are a lot of symptoms that are now included as atypical symptoms where you can consider testing someone. But we would also always say, please use your clinical judgment. And if it doesn't make sense that a patient would have COVID because they're reporting to you that they're a little bit more tired, and there's another obvious explanation for that, then perhaps they don't need to be tested. So that's the first thing. The second thing is, obviously, for those people who are tested, we need to be confident that in fact they don't have COVID. So if you're symptomatic, our PCRs, we are told, are quite sensitive. But if your test is negative and there is no or very low suspicion of COVID, or there's another alternate diagnosis, then yes, if we can get that patient off those precautions, it will definitely conserve PPE. And we certainly are trying to do that, at least within TOH. It's not a terribly efficient process. And that said, I agree that if we can get patients off when we're confident that they don't have COVID, that will help us in many ways, actually, more than just conserving PPE.
Which kind of leads into the role of increased screening. I guess that's a hard one to answer, as that's in a state of flux, because false reassurance, do you think, potentially with that?
Yeah, so screening, by screening, I think you mean testing asymptomatic individuals. And I know there's a lot of discussion about that and why don't we do this? And I honestly am not sure how our test performs in the absence of symptoms. Certainly if you're symptomatic, again, our lab colleagues will tell us that the test actually performs quite well. But there is also no reassurance that in 2 or 3 days, when you actually do start to develop symptoms that if you retested, they would in fact be positive. So it may not be a false negative. It just may be false reassurance that somebody has not become infected yet. And you know, if we could screen everybody on a regular basis, that may be a very different approach that we'd be able to take. But obviously, that's not our reality.
And perhaps the point of care may change that, but I'm also worried about so-called reactivation, where people shed again after having a negative. And you told me before that doesn't necessarily mean they're infectious. So certainly confusing for all of us, and I think we'll be learning and clearing that up through the years afterwards. But it's hard to say exactly what its role will be. So I think that's what we were going to present, Quad. I'll end sharing, and certainly I think there's some questions coming in, and I'll let you help lead that discussion, unless there's something else you prefer.
No, it will definitely hit. There's like at least a dozen questions here, so I'm going to first ask. There was some question on. I'm just trying to find Odessa and give you permission to speak here. Yeah, Odessa, you had a couple questions related to PPE and so do you mind just going ahead?
Sure. Hi, and thank you for giving me the chance. My concern here is that from listening to you, it sounds that maybe doctors haven't been given enough information on what the actual testing is for PPE. So for example, what 95, 97, 99, we all know that prevents, that's a barrier rating. But do you guys know that it's tested at 0.1 micron synthetic virus? So, you know, if information like that, and there is I understand and I appreciate that you wouldn't know this because this isn't your field, in the same breath that I wouldn't be able to, you know, look at somebody and be like, oh my gosh, they should be tested for leukemia. And there is a lot of information on performance and permeation and barriers, because the medical field is one regard, but then, you know, if you look at detoxification, people going into areas that have had gas leaks and things like that, that's yet another degree. So for example, if you realize that, you know, the average size of a respiratory particle released is between 1 and 100 microns, and within less than a second, it decreases in half its diameter. So then you're going to like 0.05 to 50 microns, and the average size of a particle is really between 0.1 and 40. So in less than a second. So I think maybe that could be the issue in terms of looking at it as an aerosol or a respiratory particle release, is that so quickly that particle dehydrates, it's still released, and it still could be floating in the air, and it still could be landing on things. But within 1 second in a normal environment, it's already half its size. And so masks are tested and materials are tested using synthetic products at 0.1 microns. So I don't know if information like that would help you guys. And you can look at like, oh, okay, you know, it's tested at 0.1 microns. The average particle size, excluding the actual virus and then the virion, is between 0.05 and 20 microns within a second. Would information like that help you? And then getting information on, okay, I'm wearing these masks, they trap particle in it. If I spray it with this, it's going to denature the virus. Or if I wash it, the virus is actually going to be released from the contact surface and wash away. Would better information that's more technical but not overly help doctors feel more comfortable? Hello?
Yeah, no. Didn't know if Kathy was going to. I don't have an easy answer for you. I mean, like the size of the virus, if it's in the droplet, I'm not sure the droplet immediately dissipates in the way of the droplet in the size that are being generated is what causes it to fall, is my understanding. So I don't know if it's a good, reasonable question, but more technical thing. I think people are confused already So I worry about confusing them more. I don't know, Kath, if you have a perspective on that.
I almost think it's too technical, but I don't know. I mean, I guess I would also put it out to whoever has joined on this call to say, you know, would that kind of information help? I mean, I don't know how many people actually think about it that way, and whether that would help their understanding or just make things even more difficult to rationalize.
Thanks for the question, though, and the comment. Paul Westergaard in Cornwall, can you go ahead and ask your question?
Hey, can you hear me, guys?
Yeah.
Hi. Hey, thank you so much, TOH Dave and Kathy Sue. Thank you for your leadership here, really helping us up in the community, because we don't have the larger IPAC teams that certainly you guys have, and so we really appreciate all your information that you're sharing with us. I have one question about aerosol-generating procedures, which I'm sure it's going to be, but I'd love to hear your opinion, because I've seen the TOH Code Blue recommendations suggesting that chest compressions are aerosolizing. And the second question is, PIDAC also says that non-filtered non-rebreathers are also non-aerosolizing, whereas it's the opposite. So those two things are opposite at TOH. One is chest compressions being aerosolizing, and the second one is non-filtered non-rebreathers are considered aerosolizing also at TOH, and it seems different than PIDAC. I'm trying to get a sense of how that came to be, the structures and the opinions that came from obviously in-house.
So I'll take the first question, which is about chest compressions, which I know we've had this back and forth discussion about. Chest compressions are not considered to be aerosol generating in the sense that they would require an N95 respirator. I know that's in our Code Blue protocol, again, being reviewed, so may not change, but it also has to do with where you get your, where you are finding evidence and what you are relying on. And I will also say that for our Code Blue protocol, I think I can't remember the date of the draft, but I think it predates the update of the Public Health Ontario most recent AGMP list. So that's under review is the short answer. And the second question was about, sorry, Paul?
Policy recommends only filtered non-rebreather masks, but the ones that are unfiltered are still considered aerosolizing at TOH. But PIDAC says any non-rebreather mask is not aerosolizing up to 15 liters. We're being cautious and trusting the TOH more conservative recommendations, so that's fine. I'm just curious to see if there's any how that might have come to be.
That is a good question, and Dave, I don't know if you have more insight.
Well, I think it's the idea, if you use it under 15 liters, like, I'm not sure how scientific and sound that is, Paul, but I think that's where that comes, that often people turn them up to flush, which would be beyond that, so potentially that. In terms of the CPR, I won't add much more than what Kathy said, other than don't forget that if you're putting an LMA in and doing bag, which is bag LMA, which is a form of a mask, that's actually on the list. And so that would be the reason perhaps to still have PPE on, not so much for chest compressions per se, but if there's bag mask going on with the HEPA filter.
Yeah, that's an excellent point. So CPR is in the Public Health Ontario list if you are also managing the airway. Yeah,
so, okay, if you're not doing bag mask, then you don't need it, but I think ultimately you'll do that. So I'm not sure we'll change it too much. Quad?
Okay, next question from Sanj.
I have a question about our definition of category 3. So it applies to asymptomatic people who have a history of exposure to a known COVID patient or a history of travel. The issue that I have with that definition is it's quite restrictive. The Public Health Agency of Canada, as of April 17th, says that only 24% of patients who have COVID have a travel history or contact with a COVID positive patient. And also, because of our limited testing, we're not capturing everybody who's COVID positive. And there are experts out there who say that the spread of the disease can happen by asymptomatic people. So Teresa Tam in 2006 wrote in her pandemic preparedness report that the pandemic can spread not only by the sick, but also the people who show no symptoms. David Fissman, who's an epidemiologist at the University of Toronto's School of Public Health, wrote, many people with COVID-19 have few or mild symptoms, meaning they may not realize they are sick. As a result, they continue to interact with others and unknowingly spread the illness.
Okay.
So based on those comments, basically our category 3 definition should be essentially anyone in the community could have COVID. And our policy currently states that for category 3 patients, aerosol-generating medical procedures should require airborne precautions. So logically, in any patient, aerosol-generating medical procedures should require airborne precautions in keeping with the precautionary principle.
So in Ottawa, I'll just put this into some perspective, which is, I think less than 0.1% of the population, or it's a very, very low number, 700 and something out of a population of 1 million, has been confirmed to have COVID. You will say that we don't know who hasn't been tested, and that's true. In Ottawa, at least according to the last update, about 25% of those cases had no clear link with either travel or contact with a known case. So I think that it's still quite uncommon, very uncommon in our area on a population basis, which I would also would translate into a random patient, like the category 1s and 2s, really probably not having a high likelihood of having COVID, number one. Number two, your risk of transmission is going to be higher if you're symptomatic. If you don't have symptoms, we don't know how well you can transmit. I know there's a lot of discussion and a lot of publications about the asymptomatic infections and spread from asymptomatic infections. I would say we still don't have a great understanding of that right now. The third thing is that this is a droplet transmitted infection. So even if you have somebody who's a contact or has traveled, and honestly, I think, this is my personal opinion, this is not what we're recommending, because that's not what the guidance is telling us to do. But I think if you have those category 3 patients, or even somebody who had symptoms, you should be protected with droplet precautions. So having a surgical mask and a visor or eye protection would still afford you, I think, adequate protection in those situations where you are intubating. There's also a very small observational study from China looking at healthcare worker exposures, where the healthcare workers were wearing either surgical masks or N95s. This was not an experimental study. It was just what was observed during aerosol generating procedures, and the most common one, I think, was intubation. And none of those healthcare providers developed illness, and they were sitting, I think it was within a 1 meter distance, actually, of the patient being intubated. So I would say that, there's the precautionary principle, but there's also taking into consideration really realistically what we know of this virus now, how it's transmitted, and what constitutes appropriate PPE. So we're not going to, or we should not be denying people an N95 respirator, but the hope is that the request, or the individual's request for an N95 respirator is based on sound principles.
Yeah, I don't have a lot to add. I think just to clarify the audience, and is talking about OR procedures. The category thing is something unique to Ottawa, so it may confuse a little bit of the general population that's listing. And I was going to cite that trial that you talked about there, Kathy. I didn't, obviously for length, didn't include it, but I think certainly with it being a droplet disorder, with the precautions you suggested would be, the evidence would say that that's more than adequate. Quad?
Yeah, I'm cognizant of the time, and I apologize for all those that have posed questions. I'm going to choose some ones that I think will have the largest impact for our audience, or we'll have a quick answer. Are you doing tracheostomies on COVID positive patients? If yes, is trach hooding or trach venting an aerosolizing generating procedure?
So first part first, yes, we have done a COVID patient. They did do their best to wait till the testing was negative, but did use full precautions doing it. In terms of trach hoods, trach shields, whatever the terminology you use, we do not consider that an aerosol generating procedure. In that, again, it's along the lines of oxygen with a mask. And again, you would use your PPE precautions of a shield, eyewear protection, along with a surgical mask is what the evidence would suggest, unless, Kathy, you think different?
No, tracheostomy is on the list, I think, for us of aerosol generating procedures. I don't have the list memorized, sadly. I should by now. And I think tracheostomy care is one where we say, do a risk assessment before you decide, but the others are not included.
Okay, I think this maybe will be our last one, because I think it will cover some of probably why many people are here. Why are so many healthcare workers getting infected and dying from COVID-19 despite using current recommended PPE?
Is that question meant to be healthcare workers globally, or?
I think that's why I think it's important to answer this question, because it's not.
I guess
we'll say yes.
I guess it's globally, because we really haven't had very many in Ontario. So if you look back at the early reports for what happened in China, the disease was not recognized. Healthcare workers were not wearing appropriate PPE. They were not necessarily trained with how to use PPE. There were issues with PPE supply. So the luxuries that we have here of at least having things and having had some lead time to know that, this was coming and what the symptoms were, have actually left us much better prepared. So that's my first comment, is just a lack of awareness and a lack of, I would say, not so much understanding, maybe it was understanding, but application of routine practice, which for us would be do a risk assessment of the patient. If their respiratory symptoms, particularly if they're viral respiratory symptoms or infectious respiratory symptoms, we would say use droplet precautions, put on a mask with a visor, and at a minimum gloves. Now we're adding gowns for COVID, but at TOH for some time, that has been the gown use has been something where we've said assess the need to wear a gown. But from reading reports early in China, that was those certainly were early issues. Then you look at also what healthcare providers in those areas have been wearing, where again, very similar to the slide with the PAPR that we showed earlier, people are contained in these full body suits, sometimes held together with tape for prolonged periods of time, difficult to get out of. We don't know how many were actually, how many were properly trained on removal, and also what the self-contamination rate was. And then I think those are probably, to me, the two biggest issues with respect to healthcare worker illness. Dave, I don't know if you have any comments.
No, certainly I don't have a lot to add because I think that will, I wish I had more information. I know there was certainly once they recognized what the disorder was in China, that the comment was the infection of health professionals went away. Now, I'm not sure how accurate some of what was being reported from there. Certainly in Italy, there's been health professionals dying from it. I guess the question is always, where did they get infected? Is a big question and a big challenge. The unfortunate health professionals who've passed away in Canada, so far the understanding was that they obtained COVID outside of the hospital from the community, so that it wasn't evidence of a nosocomial spread. But again, it is certainly an important issue, and if we had the answers, we'd share them.
Yeah, I think your last point is actually should have been my first point, Dave.
Yeah, I think this is why this is such a, I mean, the demand for this topic is so huge. It's that fear of contracting COVID-19 and how that will impact healthcare providers. So I want to apologize for those that we didn't get to your questions. I think you can send some questions my way and I'll direct them to the appropriate people. I really appreciate you guys taking the time to hear us out, and I really want to appreciate or give thanks to Dr. Sue and Dr. Neilipovitz for taking the time in their busy schedules to be able to have this discussion. I mean, personally, I learned a lot. Like personally, even that concept of, aerosolizing versus, airborne, I don't think we have that discussion enough, to be honest with you. Like, I think that has a lot of clarity in terms of why our recommendations are the way they are. So I really appreciated that part of the discussion. Yeah, thank you very much. And for those that, in terms of audience members, we're also going to send you the recorded version of this. That should be done by this afternoon. And stay tuned for more webinars on COVID. The feedback's been unreal, and I hope you find it useful. Thanks so much, guys.
Thanks, Bud. Thank you, Kath.
Thanks for the invitation.